injections. And anticoagulant drugs, basically the heparines, low molecular weight and unfractionated. These are basically factor 10A inhibitors. Others are basically platelet ADP receptor blockers, thromboxane A2 inhibitors, and platelet P2Y12 inhibitors are the clopidogrel group of drugs, platelet P2Y12. So they basically, these anticoagulants and antiplatelet drugs together inhibit the formation of the thrombin or platelet-rich clot inside the exposed atherosclerotic plaque. Okay. Rivaroxaban is also available. It's an oral form of anticoagulation. Instead of warfarin, you don't need to measure the INR. In fact, INR is useless because factor 10A inhibitor, just like low molecular weight heparin, but in oral form, right? Fondaparinux or something like that. And then bivalirudin, it's a derivative of the leech hirudine or hirulog analogs. These things are not used in Sri Lanka and probably going out of fashion in the world as well. So we are left with low molecular weight heparin. Out of that also, it's enoxaparin, not fondaparinux. Fondaparinux was quite much used early in Sri Lanka and UK, gone out of fashion now. We are dealing with enoxaparin, aspirin, clopidogrel, and probably ticagrelor in our country. And GP2B3 inhibitor wise, probably what is called abciximab or brand name Riopro. So those are the 5 drugs that we are involved with, 5 or 6. So platelet inhibition in NST elevation and acute. Now in these guidelines, you see these 2 columns here. First is basically the class, and other one is the level of evidence. Class is basically 1, 2, 3. Green ones are basically from they are very confirmed recommendation. 3 is asked not to do that. 2 is in between, A and B. The level of evidence, A is the best level of evidence, as you know, from multi-center randomized clinical trials. C is just consultant opinion. B is in between, probably not double-blind studies, right? Okay, so aspirin at a dose of loading dose of 300 and lifelong, basically 75 to 100. Okay, aspirin, class 1. T2I12 inhibitors, clopidogrel is what we use here, 300 to 600 loading dose and 75 daily dose. These usually stopped after 1 year, but can continue more than 1 year in high-risk patients. Type 2 indication. Then ticagrelor is the one that we use, 180 loading dose, 90 twice a day. After 1 year, you have to reduce the dose to 60 twice a day and go up to 3 years. It's probably a more antiplatelet effect is there, and there's higher risk of bleeding than with clopidogrel. And if you are using ticagrelor, your aspirin dose has to be maintenance less than 100 milligrams a day. Okay, so antiplatelets, and when you are giving antiplatelets in high-risk patients, there's always a risk of GI bleeding, and you have to start a proton pump inhibitor also, preferably the pantoprazole, which is shown to have the least effect of reactions with clopidogrel and P2Y12 inhibitors. Okay, and in addition, we have to start enoxaparin at 1 milligram per kilogram subcutaneous twice a day. So the enoxaparin, when you go to the wards, have a look at them. They are usually yellow or orange pre-filled syringes at 60 units or 80 milligrams, 60 milligrams or 80 milligrams. Vials. So basically, if you had 40 and 60, if I remember, 40 syringe, you can, if you have to give 80, you can use 2 of those. 60 milligram is the standard dose. If you are going at a lower level, say 50 or so, then the nurses will throw out part of it and give it the balance. Subcutaneous pre-filled syringes kept in the fridge, 5 centigrade compartment. Okay. Fondaparinux as mentioned here, even the unfractionated normal heparin, which was we used earlier in a continuous drip with AP with ACCT monitoring, is no longer used due to the difficulty in monitoring, but we use enoxaparin most of the time. Okay, class 1 indication. be familiar with the pre-filled syringes. Okay, so the risk stratification. The second step, as I mentioned earlier, first you start the dual antiplatelets after diagnosing, and then you start the anticoagulation or antithrombotic drugs. Then you have to risk stratify whether to send for early intervention or not. Now, this is what you do. If they are very high risk, you have to do intervention like for a STEMI within 2 hours, 120 minutes. If they are at a high, not very high, but high risk, then within 1 day, intermediate risk within 3 days, and if not, you can send them and get them down. This is basically what it says, whether you are at a PCI capable center or not. Still, if they are very high risk or intermediate, you are supposed to transfer them when the within 24-hour patients within the same day. Intermediate one you have to transfer. Immediate transfer, if you have to do it within 2 hours, obviously. And these are the criteria: very high risk and high risk. Now you can use what is called a GRACE risk score. It is actually not provided to Sri Lankans, but basically it is uses certain criteria like whether the patient, the depth of the ST elevation, ST depression, whether they were already on antiplatelets, and ongoing pain, hemodynamic instability, serum creatinine levels, heart rate, blood pressure, those things. And it's a calculator. Basically, it gives a score. Anything more than 140 is considered high risk. Dynamic changes and cardiac troponin going up and down, indicating acute thing. But let's concentrate on the very high risk criteria when there's hemodynamic instability, cardiogenic shock, bad arrhythmias going on, and heart failure, and particularly ST depression, as well as going into ST elevation. That is the 99% blocked artery clot is getting fully occluded also at times. So those are the very high risk. It's like a STEMI. You have to do intervention within 2 hours. Those are very high risk, the red guys there, right? Okay. So the secondary prevention things, basically after you manage the acute things, it's how to advise the patient as well as the other pharmacology of all the other drugs, starting basically lifestyle advice, and which we'll talk later. It's common to both acute and chronic. The drugs, the secondary prevention drugs, statins, beta blockers, ACE inhibitors, and mineralocorticoid antagonists, that is spironolactone if there's heart failure, and other medications if they have diabetes, diabetic control, and hypertension control, lipidemias, hyperlipidemias, cholesterol, what levels to control. You probably need to know that from your medicine point of view. But for pharmacology, as that was given by Professor Priyadarshini, you probably need to know some of the pharmacological aspects of these drugs and what drugs we are going to use and when. Okay, so here just to highlight that in Sri Lanka, all patients' lifestyle changes, all patients' high intensity statin. Now, high intensity statin is atorvastatin at a dose of 40 or 80. That is to bring down the cholesterol levels in patients with acute coronary syndromes less than 55 milligrams per ml deciliter, 55, and by 50% and 55. That is less than 55. If it is starting one was lower, say 90 or so, then you have to bring it to 45. That is 50% less than the initial one, whichever is lowest, right? And if it is say 200 LDL, then you have to bring it not just 200, but up to 55 somehow. So if you start with, to do that, you have to start with high dose statin, that is atorvastatin 40 or 80, depending on the risk again. And if I time, I'll show a quick graph there. And then basically, you have to add on other drugs if that is not, statins are not enough. There's a drug called ezetimibe, oral drug, you can add that. Class 1 evidence is there, but not alone instead of statin, but first statin, and to that you can add ezetimibe. And then there's a new intravenous drug called PCSK9, PCS3K9, that is not available in Sri Lanka, but trials were done here as well, international trials. It is recommended in the current guidelines for very high risk people to reduce the cholesterol. Then you have to start number 3 ACE inhibitors if the heart LV function is less than 40. Beta blockers also specific types of beta blockers, carvedilol, metoprolol, bisoprolol, and nebivolol only if there's heart failure, not atenolol, propranolol. Those will worsen heart failure, right? Okay. So mineralocorticoid receptor again, if the heart failure is even lower, 35% or so, spironolactone. If you get anti-androgenic effect with spironolactone, you can start on eplerenone at a dose of 25 milligrams once a day or twice a day, or you can start with 12.5 once a day or twice a day if the pressure is on the low side. So your blood pressure goals are less than 140 systolic and less than 90 diastolic, ideally even less than 85 millimeters if it is a diabetic. Now, some of these pressure things vary from each year when they put out the new guidelines, but generally, if you remember less than 140/80, or sorry, 140/90, it is good. And your cholesterol target, according to latest guidelines from last year, in very high risk people or those who have established coronary artery disease, they are considered very high. LDL less than 55. Okay. Here it says more than, if it is more than 70, reduce up to that level, but it is now it is considered 55. Okay. So audit standards are basically all those things we told you about earlier. Timing, how when you manage patients like that, you can do a small audit in your hospital and present to your the clinical societies there when you pass out, how efficiently and how much according to the guidelines you are practicing and managing your patients, whether you have done those investigations. They recommend doing this LDL, food blood count, creatinine, ALT for statin use, HbA1c diabetic control or fasting sugar, prescriptions whether you are given the dual antiplatelet therapy loading, anticoagulation appropriately, proton pump inhibitor, secondary prevention drugs at time of discharge as we mentioned, risk stratification and whether you have done appropriate timely revascularization. Then you have to always do echocardiogram before they are discharged to assess in adding various drugs and to risk stratify as well at that point. Then risk factor control targets whether you have achieved diabetic hypertension, LDL levels and smoking cessation targets, and lifestyle advice and cardiac rehabilitation program enrollment. So we'll talk about the diet and the exercise, what you tell the patient, because that is one of your the mentioned aims in this lecture. Okay, so the chronic coronary syndromes, we have finished the non-ST elevation acute coronary syndromes now. We are coming to the chronic coronary syndromes now. And here we showed you this chart earlier. What happens if you follow the good things and what happens if you follow the bad, don't follow them. So the three things: lifestyle, which includes three things again: risk factor control, healthy diet and exercise. Number 2, secondary prevention medication. Number 3, revascularization when needed, right? So this is chronic coronary syndrome. Now, who are chronic coronary syndrome? As we mentioned here, 2019, guidelines have been revised to focus on chronic coronary syndrome instead of stable coronary artery disease. Earlier, this was called stable angina, stable coronary artery disease. There's nothing stable. You remain stable only as you are good as only as your how good your risk factors are controlled, right? Okay. This change emphasizes the fact that the clinical presentation of coronary artery disease can be categorized either as acute or chronic. As I mentioned earlier, coronary syndromes are now classified acute or chronic. So chronic coronary syndrome people basically are mainly these 6 types. Patients with stable anginal symptoms, that is when you walk you get the symptoms, which we actually call stable coronary artery disease earlier, but those are patients with anginal on exertion. So those are categorized as one group which consists which makes this diagnosis. Number 2 is patient with new onset heart failure or suspected coronary artery due to suspected coronary artery. Number 3 is these patients within 1 year, even now, let's go to 4 first. 4 is patients who have basically after initial diagnosis of acute coronary syndromes or after stenting or bypass 1 year afterwards, whether they are asymptomatic or symptomatic, they are considered as chronic coronary syndromes. Of course, they can get acute coronary syndromes on top of that. Number 3 is basically patients even within 1 year if they are have stabilized symptoms, even within 1 year of acute coronary syndrome or within with the recent revascularization but stabilized symptoms, you can still consider them as chronic coronary syndromes. You don't have to wait 1 year. After 1 year, initially, of the initial event, anyway, they are considered whether they have symptoms or not, chronic coronary syndrome. Then patients with angina and suspected vasospastic or microvascular. Now that these are one of the type 2 MIs where you basically do the angiogram and it is normal. You suspect vasospasm or microvascularity, not the big arteries that we can see with the angiogram. Tiny vessel disease, right? Then if you detect patients who don't have angina, but you for whatever reason you do some test and you find that they have coronary artery disease, and then at screening, then they are also fall into the chronic coronary syndrome group. Okay, so the angina that we are talking about, basically there are 3 types of when somebody comes with chest pain. Typical angina, where it's discomfort in the front of the chest going up to the neck or shoulder or arm or jaw. Especially if it goes to the jaw, it is very significant. Precipitation by physical exertion and relieved by rest or nitrates within 5 minutes. So exertional angina or angina type of chest pain brought on by exertion, relieved by rest. If you don't have all 3 and meet only 2, then it is atypical angina. If you don't have any of those, then it is probably non-anginal chest pain, something like it's not brought on by exertion, or you have pain when it comes with exertion but doesn't stop when you stop the exertion, something like that. So that is non-angina. Now the angina, the typical angina, it is called CCS classification. Chronic CCS stands for chronic coronary syndrome also. So here on we'll probably need to just say Canadian Cardiovascular Society grade. Earlier CCS stood for Canadian Cardiovascular Society. So angina grade 1, 2, 3, 4. 4 is angina trace with the worst one. You might even call it unstable angina. 1 is only with minor exertion. So class 1 to 4. Now, what do you do if you have somebody suspected of coronary artery disease? Now, this is a nice stepwise approach. You assess the symptoms and do the clinical tests, which are basically the ECG and troponin and that sort of thing. And if you think it is unstable angina, then it is basically the top part of the lecture today, acute coronary syndrome. Then follow the ACS guidelines, do the ECG. If there's ST elevation, start the reperfusion clock, give thrombolysis or primary PCI and aspirin dual antiplatelet, that sort of things. If it is no ST elevation, then do the troponin. If that is positive, treat as what I have been talking so far, non-acute non-ST elevation, acute coronary syndrome with antiplatelet loading, anti-thrombotics, right? If there is no unstable angina, then you come to step 2, consider comorbidity and quality of life. Somebody very old, futile, and if you think basically doing stenting or angiogram is not useful, then it is medical therapy. The whole idea of this stepwise approach is to see whether you can do anything more than medical therapy, and those to pick up the people down these steps who will benefit from angiogram and stenting, okay, or bypass. So if basically at that point, next step 3 is do echo scan. If you see wall motion abnormalities, now you have 3 coronary arteries, and if one is blocked, that area supplied by that artery will not contract efficiently. So in the echo scan, you can see we have divided the LV into 16 segments from various views. If 1, 2, 3 goes down, then you know that this part of the mid part of the anterior descending artery is blocked. Like that, you can suspect. So if the overall LV function is less than 50, again, section 4 is basically not in this slides. It says you have to go for a basically invasive angiogram or probably think about looking at the arteries, right? Then if that is also not there, if the heart function is also good, then you have to do further tests depending on the pre-test probability of coronary artery disease. So if the pre-test probability is very high, you might even need to go for a straight away for an invasive angiogram, that is putting a catheter into the artery, injecting dyes, going up to the heart and injecting dyes into the coronary artery. Okay, so that is very high risk. We don't usually do that for very simple reason. You like to do something like exercise CG or what is called calcium score or what is called coronary CT angiogram. Excuse me. That does not it's not an invasive test as such. Although you give dye in the coronary CT angiogram through a cannula into the vein, when it goes through the arterial phase, you take the pictures. Whereas invasive one is where you go into the left side or arterial system. So that is done according to the pre-test probability. Clinical likelihood of obstructive coronary, low or high. Then based on those things, then you decide on whether to do invasive angiogram, step 6. Okay, so what are the things that you consider as low likelihood? If the if you ask them to do a non-invasive exercises, and that is normal, and if there's no coronary calcium by CT, that is called a Agatston score equals 0, CT calcium score, just a simple CT scan, few seconds only, then you think probably that they are very unlikely to have coronary artery disease, and you probably not going for a very high investigation. You can even drop it at that point. Then if increased likelihood, then things like multiple risk factors, ECG changes, typical symptoms, then LV dysfunction, high calcium score, then that sort of abnormal exercise, then you probably want to go for an invasive angiogram somewhere here, coronary CT angio, non-invasive testing. Those are the exercise and things, and invasive angiogram finally, if those things point to that. Okay, so basically that we are not going to talk very much about that. That is for interventional cardiologists. But from your point of view, you need to know what to advise the patient about the lifestyle changes and the medications you are going to write on the patient's drug chart, as well as the prescription you are going to give them.